take your jackets off. You can make yourselves comfortable. Welcome all, and good evening. You all look so familiar from so many sessions. It's kind of scary, but it's wonderful that you still have energy and interest. On the one hand, I think as many of us have said, it feels like, how can we keep talking about this? But on the flip side, how can we not keep talking about the issues at play in terms of figuring out what we're going to do with all this new, rich, important information? What we're hoping to do tonight is to get as far away from presentations, from speeches, and from long discourse as we possibly can. We're going to facilitate that by trying to end this, although it says 8:30, we're going to try to end the conversation here by 8 and have what will hopefully be even more interesting discussion over wine right after that at a reception. So I hope that we can be brief enough to get out of a dark, windowless room, but in depth enough to really come to terms with what it is we're going to start doing on July 20th and July 21st and beyond. I could not be happier with the panel that is sitting here with me tonight. What we really want to do, and this was a joint effort by a number of different organizations, to think about what's the best way to ensure there's a conversation about all of this rich new information. And no session room really allows enough time for conversation. So we're going to keep, I'm going to try, and I'm not very good at this, but I'm going to try to keep very strict time, not only with the panelists, but with all of you. If we can keep constant motion, 2 to 3 minute maximum, whether you're sitting at this table or sitting out there, to really get a conversation going. This is not the first of these debates. This is not going to be the last. So it's not as if this conversation ends at 8 o'clock. But we really want to try to get to the heart of a number of issues. So the format that we're going to work on, at least try, is I'm going to ask each of these wonderful colleagues a question. They're going to be very brief in their answer. In theory, we'll go through a question to each, but as the conversation unfolds, we may get distracted and happily take questions from the floor. We really want this to be a conversation. You know, I don't know that I need to introduce many of these people because you see them and have heard from them so often. And I'm not sure, I can't even see that far down to the right, but in no particular order, I think, we have Steph Bertozzi from the Bill and Melinda Gates Foundation, who directs the HIV/AIDS program and TB program there at the foundation. We have Mike Cohn, who you may have seen yesterday, present some important and interesting data from HPTN 052. Paul DeLay is the Deputy Executive Director of UNAIDS. Tony Fauci, Director of the National Institutes of Allergy and Infectious Diseases at NIH in the United States. And if you didn't see his lecture yesterday at 1 o'clock, it should have been required viewing before coming to this session, but you should check out the webcast. Bob Grant, who led the IPREX trial, amongst other things, and is at the Gladstone Institute. Gottfried Hernschel, the Director of HIV/AIDS at the World Health Organization. Helen Reese, who's the Executive Director of the newly named, and I always have a hard time remembering the new name, the Reproductive Health Institute of the University of the Witwatersrand, formerly the Reproductive Health and HIV Research Unit. And Memri Sakikonye from the Global Network of People Living with HIV. What we really wanted to do was bring diversity of researcher disciplines, of policy making, of community, of country, to really come to terms with where we are and, more importantly, where we go next. So as I said, I was going to just throw out a question to each one. I thought I might start with Dr. Fauci. I actually put one of your sentences from your 600-word article up just a little while ago. And you ended it by saying, you know, if one accepts the tenet that science should inform policy, then the scientific data are loud and clear. And we're not going to spend a lot of time reviewing the data necessarily. But you went on and said, global policymakers must seriously consider these new data in their priority setting and decision making. So you sit at one of the leading agencies, certainly on the research side, and what does all of this mean for you, and what are the new priorities and new decisions that you take out of this robust data coming out?
Well, thank you for the question, and I hope that we can, as you suggested, get a back and forth with the audience, so I will really be very brief. I made it as simple as possible because I said what I meant, and I meant what I said, and that is that when policies are made and policies can be implemented, there's sort of three phases. Is what is the fundamental basis upon which you base your policy? Do you agree with a policy of going in a particular direction, which we all do, that we really do want to control and ultimately end the AIDS pandemic? And will the reality of the situation, the politics, the economic realities, follow the policy? So that's, in my mind, it's a complicated, but it's a three-step process. Not infrequently, when we go before funding bodies, or we go before our Congress or our president or whoever that president may be, because we've been through now 5 presidents that I've dealt with since the beginning of the epidemic, whenever you come with a proposal and a recommendation, they do in good faith ask the scientists what the scientists think. And sometimes if you come in with a pie-in-the-sky thing that scientifically is not sound, there's a great reluctance to even implement a policy to get to the point you want to get. So one of the really, really important things, if you are going to, in good faith, make a strong argument, even if it's not going to happen right away, is, does the science tell you that you can do this? Now, you know, I can't tell you right now, although we are going to support it, that we will have a cure for HIV infection. So I can't go in and say to a president or to a Congress, we're definitely going to cure HIV, so let's go cure it. But what we can say now, based on the cumulative data that I reviewed yesterday, is that we can say the science has clearly shown us that the following is attainable. So we need 2 things. We need a policy that says we really believe that it's attainable and we're going to try to attain it. And then you're left with the reality of, can you do it? So that scientific basis is a huge step. And that's the reason why we got to make sure that we delineate the difference between the two. We are now on solid scientific basis that even without a vaccine and even without a cure, that we could have a major impact on turning around the trajectory of the pandemic. That's huge. So that's what I meant in my 600 words when I said that, you know, next time I go downtown, which will probably be in about 4 days, downtown, not downtown Rome, but downtown Washington, and talk about this, they're going to ask me, what were you saying in Rome? And I'm going to say, I'm saying what I've been saying all along, that as a matter of fact, if you look at the data, it's doable. Are we financially able to do it now? That's something that I don't have control over, but I can tell you for sure, scientifically, what we can ultimately do.
That's great. Speaking of science, you know, Mike, you presented yesterday the 052 result. In conversations just after the press conference a couple of months ago, you were very clear that you were not going to talk about what next until the data was out. So the New England Journal published, you presented. What are you saying is next when you're asked as a scientist?
I guess I pretty much, there's a couple of points I'd like to make. The first is, I think we have to focus on the fact that we can now, and this is kind of following on what Tony said, it's very easy now to say that as we offer treatment and reduce viral load, we render people less contagious. That's just a given, and I think that really can be used to put wind behind both the policies and the funding, because either we pay now to achieve this goal or we pay later, and it's much more painful, I think, to pay later for everyone involved. I think the study design has created a little bit of confusion that I want to straighten out. The study design, to do it ethically, required that we really investigate the benefits of earlier treatment. We did that, and we saw benefits in earlier treatment. But that doesn't mean we shouldn't focus on treating people whose CD4 counts fall lower, because they're going to realize the same benefits, and their clinical benefits will be greater. So I want to avoid any confusion about the study design. It's not like the 052 team is advocating shifting towards only treating people with higher CD4 counts. The 052 team was focused on demonstrating unequivocally that treatment serves to reduce transmission probability. We've done that. That will extrapolate to heterosexual transmission at lower CD4 counts. And I think our real obligation is, at least in the United States, is to identify as rapidly as possible people who are infected and give them the opportunity to go on treatment. And I think we will see a benefit for the communities involved that go after that goal. So I'll stop there.
Great. Thanks, Mike. You know, we have a global perspective, the scientific perspective. Helen, you not only direct the Institute, but are also co-chairing the development of the next National Strategic Plan. When push comes to shove, you know, infections happen locally, they get prevented and treated locally, at least at the South African level. How does all of this noise in the system get translated into the National Strategic Plan?
Yeah. I mean, I think, I'm not sure if this is a good thing or a bad thing, but all of this information has come out just as we're writing our National Strategic Plan. We have to have this finished by 1st of December. So we've been looking, obviously, the first thing we looked at, obviously, was 052. And this is really where sort of science hits the road and hits the difficulty. And one of the things in terms of implementation science that we haven't talked enough about is giving tools to countries to prioritize. It's extremely difficult to know how to do that. So we're deciding, do we buy 1 billion condoms? And if so, will they get used? Do we circumcise more men? Or what do we do with the 052 data? So what we're saying in 052 is that we would aim in the next 5 years to get everyone with a CD4 of 350 onto treatment. Now, we're not saying it's not open. We're not saying it's not test and treat. We're first of all going for 350, but we're also supporting demonstration sites. So we'll have demonstration sites which would go for different versions of test and treat that might have a feasible approach. But it's the cost, and that's why we've stuck first at 350, plus our average starting is about, CD4 is about 100, 110. We're only covering about 45% of the people, if that need to be on treatment. So that's the first thing. I think then it starts to get a bit more complex, actually. I think that's almost the easier bit. IPREX was done in a Cape Town site. There's access for the participants, the MSM participants in Cape Town. But we're now saying, as part of our services to MSM and the new National Strategic Plan, do we include this? And if we do that, that's a brand new service that doesn't exist. And every time you set up a brand new service, there's a massive cost implication. Partners Prep is extremely exciting, but in our setting, we find it very, very difficult to identify discordant couples. So we have to say in our setting, is that a priority? Because we would again have to put in quite new processes to identify discordant couples. However, there might be a priority in looking at women who are asking to conceive. And we haven't thought about it. If we were going to prioritize, I think, the numbers of young women who are positive, who are wanting to get pregnant, that's the kind of thing we might pick out of that environment. And then finally, I think one of the things that I think is more difficult, and I think it goes back to what Tony's saying about, is the science robust enough, is at a general population level, do we think with, on the one hand, the CDC data, on the other hand, FemPrep, and with voice still in the field, is that strong enough data for us to say that we are now going to go for PrEP, which is a brand new service, which we have no way currently of knowing how to do it? Or are we saying, actually, that science so far is not robust, we want a bit more data before we go into the field? And putting a regulatory hat on, I would want to see a bit more data. And I think it's important that we get that voice data out there.